Dietro per favore. Ok, questa è l'altra domanda. Quando si utilizza la colla è ancora necessario identificare i nervi? Questa mattina è stato risposto che anche se usi la colla è stato risposto che è necessario si suggerisce di identificare i nervi. Utilizzare la colla non vuol dire non identificare i nervi. Parviz, you can comment anytime. You can comment anytime. Another microphone, okay.
If I remember correctly, answer to should we identify the nerve in spite of glue was yes.
Yes.
But removing the fascia was a suggestion. But identification, Campanelli said yes.
Yes. No, we are talking about that.
Oh yes, that's right.
Ok, we agree. Andiamo avanti. La prossima. Se la colla invece della sutura diminuisce il rischio di dolore cronico.
Again, as I remember, the answer to this was no. Because you have to use the same precaution as far as identification of the nerve and protection.
I think when I heard to Campanelli, he was not able to answer the question. So the answer will be 3, don't know. We don't know. We shouldn't use glue until we have more studies.
No, but that was not the question. So I don't remember. Maybe that's all.
How many votes? Don't know, yeah.
Io sono completamente disaccordo perché secondo me è chiaramente don't know, number 3. Cioè irrazionale, insomma potrebbe anche essere il numero 1, però va dimostrato.
Se mi permettete, io credo che bisogna stare molto attenti quando si risponde così, perché c'è stata una relazione, come ha detto il professor Kellett, che non è stata assolutamente conclusiva su questo. Gli studi della letteratura suggeriscono, ma non sono assolutamente conclusivi. Quindi, prima di scrivere una cosa di questo tipo, che se poi questa viene pubblicata ha una rilevanza non da poco, io starei molto attenti.
Your opinion, Parviz? Number 1, 2 or 3?
I just have to use my imagination. Well, let's assume, we already had the answer to the first question, that when we use glue, we still have to identify the nerves. Now let's assume that we identified the nerves, but at the time of putting a suture, we catch the nerve, which is going to be very unlikely, but if we use glue, we're not going to do that. So my answer would be
No, it's not that. Yes, not, don't know. It's not this one.
a very, very, very weak yes. Stretch of imagination.
Questa è l'altra domanda, se c'è nessuna differenza, secondo voi, secondo quello che avete sentito questo pomeriggio, tra identificare e non identificare i nervi durante l'intervento di ernia chirurgica rispetto al dolore cronico? Se c'è differenza, non c'è differenza, non lo sappiamo. Vediamo cosa abbiamo fatto stamattina. Mentre aspettiamo la votazione, questa mattina c'è stato un accordo ritenendo che i nervi vadano identificati e protetti, ma tutti e tre, sia nella relazione del professor Isard che ha fatto uno studio senza mesh, sia negli studi con mesh. Vediamo adesso l'aula. Parviz, if you want to give any any moment you
No,
can...
I agree completely. Dr. Wantz, probably he's known to most of you who unfortunately passed away several years ago. He was a Scholdice person. Then he switched to Liechtenstein, and he reported about 1,500 cases. At the beginning of his series, he did not put suture on the upper edge of the mesh, and he had some recurrences. Then he started putting suture. And the reason is, first of all, there is only need for 2 sutures on the upper edge of the mesh. One of them to the rectus sheath and the other one to the internal oblique aponeurosis on the above the inguinal ring, exactly across the last suture on the inguinal ligament. Now, these 2 sutures will keep the mesh tightly in place, so when the intra-abdominal pressure increases, instead of the mesh slipping, and I'm referring to only the first month of the operation. After the mesh is incorporated, then that suture is out of business. But during the first month, if that suture is not there, intra-abdominal pressure, when it increases by coughing or whatever, the mesh can slip, and then there can be an early recurrence. But if you put that suture, when the intra-abdominal pressure pushes this way, the mesh will push in the opposite way, and it will stay completely intact. So from the very beginning, we have been putting the suture on the upper edge of the mesh. I don't have personal experience of what's going to happen if we don't, but I can refer to the experience of Dr. Wantz. Actually, his article was in the Journal of American College of Surgeons. At that time, it was not American College of Surgeons. It was in SGNO, Surgery, Gynecology, and Obstetrics. So I guess I didn't finish it. So if you agree with me that you have to put a suture on the upper edge of the mesh, then you have to expose the internal oblique aponeurosis in order to suture it. Because as I said, it is risky to suture the mesh to the internal oblique muscle. Now, when you expose the internal oblique aponeurosis, automatically the ilioapic nerve is there. You don't have to do anything special about it. You see it. And you don't, of course, you see it, but you don't touch it.
So just to manage this question, I think it's important. If you don't put the stitch, not you, me, you really need it for you to identify the alopegastric if you don't put stitch on the medial part?
No, I don't think so.
Okay.